Ես մի բան ասեմ էլի, չգիտեմ լսում եք ինձ թե ոչ, ես չեմ լսում, շատ լողում է ձայնը, հնարավոր չի, կարող է ինչ-որ մի բան էնպես չի։
Այսինքն ձայնի որակը լավ չի, հա։
Հա, ես չեմ հասկանում, այն ինչ որ խոսվում է, հնարավոր չի լսել, որտեվ լողում է ձայնը, միգուցե չգիտեմ, իմ հեռախոսից կարող է լինի թե
այստեղից է։ Ինձ թվում է դա ձեր հեռախոսից է, որտեվ ինձ մոտ ամեն ինչ շատ պարզ է, մեկ-մեկ ալեն հենց մոտից էխո է լինում, բայց ընդհանուր առմամբ լսելի, հասկանալի է։
Հիմա այսօր ասեցին, որ Ապերը շատ վատ են եղել եւ առավոտը մենք դա չէինք արել։ Կամ դրա հետ է կապված։
Այսօր շատ վատ է եղել, հա, այսօր հնարավոր չէր, բայց ես հեռախոսով եմ միացել։ Լավ, հիմա փորձեմ։ Լավ չի լսվում, բան չեմ լսում ճիշտը որ ասեմ։
I'm recording, Alan.
Okay.
Okay, and I'll share it with you.
Yeah. Well, once in a while, we may just interrupt and try to do a spontaneous translation at the same time for people who may have difficulty comprehending the content in English. So I hope you don't mind.
No, absolutely. Okay. Jump right in. Okay, so the whole point of this slide is that for as many deaths there are from traumatic brain injury, there's multifold more that don't even visit clinical care. So the burden of traumatic brain injury is much larger than the numbers that end up seeking clinical care. So there's some language around military brain injury. Again, I'm going to leave this up here. Obviously, this is not going to be as relevant to you, but the idea being that most of the brain injuries that are reported in military populations tend to be in that milder range, and that's what I'm going to focus on specifically today. There's different types of brain injuries or different factors that can cause a brain injury that are very specific to a military setting. There's the ballistic injury, which basically is an injury from objects that can pierce the skull. So whether that's a bullet or anything else that can enter the skull and the brain and cause damage. There's a blunt injury that is the result of the head encountering an object that may cause a bleed or bruise or any kind of brain damage that would be related to a collision, the brain moving within the skull and making contact with another object, or a forced kind of rotational, even if there is no contact, a forced rotational movement in the brain. And then very specific to explosives and injuries related to a blast are 4 different factors that would create brain damage that have to do with a blast-related injury. So in this picture, what's depicted here is initially the primary injury is a shock blast injury. So there's again, a sudden rotation in the skull that moves the brain in a way that can cause disruption. It could be any kind of force, that initial force that moves the brain in the skull. Secondarily, there may be debris or other fragments from the explosion itself that can lodge or impact the skull or penetrate the skull and the brain. And that would be the secondary injury from this kind of blast-related injuries. Thirdly, when there is a sudden movement like this, any kind of impact with another object. So if a body is thrown and then hits another barrier or hits the ground suddenly, that again may be causing a concussive type of injury, or in more significant situations, a brain bleed or contusion. And then fourthly, following these kinds of injuries, there may be some debris or other impact from the blast that can cause additional injury, whether that's a gas, toxic gas that's released, or a fireball. So the point of this is military-related, blast-related injuries are complicated because they have multiple ways to impact the brain, and sometimes all of these factors are at play all at the same time. And when we talk about a brain injury, there's the initial injury. So all of the things we talked about, the initial direct damage that's done from the injury to neural tissue and how the tissue, neurons are connected, if there's a bleed, if there's a fracture, if there's a bruising or any kind of shearing. That's the initial level. But what may complicate a brain injury is the second level of consequences that happen shortly or even significantly after that initial injury, which is an imbalance in the neurotransmitters and the neurochemicals in the brain. There might be excitotoxic kinds of events if there's an exaggerated response for the body to harmonize or normalize what's happening to the brain, mitochondrial dysfunction, a number of other things that could happen hours, days, and sometimes weeks and years after more significant injuries that continue to cause problems and continue to cause symptoms following a brain injury. Do you want me to stop there, Alan, so that can be summarized, or would you like me to continue?
I was monitoring the chat box, and most people responded that presenting in English should be fine.
Okay.
Unless if there are any concerns, I would suggest we move forward with English, and at the end we can stop, and maybe you can also sum up, because I know you speak fluently as well. So if there's any points, take-home messages that you would like to say in Armenian, that should be fine.
Okay, okay, all right. Real quickly, focusing on mild traumatic brain injury, because that's the bulk of what we see in civilians and in the military population. There are different methods of classifying what constitutes a mild traumatic brain injury. And I'm not gonna go through all of the different methods, but in general, if we think of the Glasgow-Coma scale, that is a very quick screen on eye, verbal, and motor responses right after an injury. Mild would be considered 13 to 15. 15 is the most score you can obtain on that measure. Moderates would be 9 to 12, and severes would be 3 to 8. So that's probably the most common way of classifying how severe a traumatic brain injury is. There are other definitions. The one that's more relevant to blast-related brain injuries have a slightly different way of classifying severity based on how long LOC, which is loss of consciousness. So for how long did the person lose consciousness, and PTA is post-traumatic amnesia. So if they would be considered to have a mild injury if their loss of consciousness was less than an hour and they didn't lose memories for less than 24 hours. For greater than 24 hours. So if it's less than that, then they would be considered in this mild range. The complications from a more severe traumatic brain injury are listed here. There's certainly medical complications like the beginning of seizures and epilepsy, hormonal issues, if there are particular structures in the brain that are affected. There's certainly cognitive deficits in terms of memory and attention and ability to have vocational prospects. Absolutely changes in personality, and these are things that families and interpersonal partners can pick up in terms of changes in motivation or depression or impulsivity even. Chronic pain can be an issue, especially migraines and headache. Daily adaptive functioning can be affected, so these are things like being able to cook and buy groceries, pay bills, manage our day-to-day functions. Physical limitations, obviously, if there's damage or any kind of impairment in walking or using extremities. And then mood and self-esteem are big ones too. And several years ago, my mentor and I pulled together all of the outcome literature on pediatrics. So again, this is focused on individuals up to age 18 to see what the chronic consequences would be of cognitive outcomes related to different severities of injury. And when we combined all the literature and all of the data points into this one figure, we summarize the findings as, if we consider this solid line being normal development, so if a child is developing over time, and we look at the different injury severities, mild being the dots, and then moderates and severes, we see that the milds initially have some difficulty relative to their healthy or normal control counterparts, but for the most time they catch up. So there should not be a long-term consequence, at least in cognitive outcomes in that mild group. The moderates and the severes look closer together, more similar. The moderates may continue to have some deficits as time goes by, but they're able to maintain that same level of advancement and development over time. What was striking was in that severe group, as time went on, because of their cognitive deficits, the difference between them and their healthy control counterparts was larger over time, which suggests that at least when we look at a younger cohort, when we look at youth over time, we may not be able to tell deficits earlier on because there is continual growth and development that happens as time goes by. So what are the cognitive deficits that we see after a brain injury? And it's pretty much across the board. It's all the things we're interested in that impact our daily functioning, our academic functioning, our vocational functioning, just general intellectual skills, learning and memory, attention, processing information, organizing information, motor skills, and then obviously the psychiatric and the behavioral piece in terms of an impulsivity and difficulty regulating emotion, but also mood, depression, and things like anxiety.
Talin, if we can pause in here for a second and just give a chance to people if they have questions or if there are any reflections, that would be great. Կան ինչ-որ հարցեր կամ ինչ-որ տարբեր կարծիքներ, եթե ինչ-որ բան պետք է հայերենով ասենք։
Այստեղ փաստորեն կոգնիտիվ հետևանքներն են, որոնք կարող են կապված լինել տարբեր գլխուղեղի գանգուղեղային տրավմաների տարբեր հետևանքների հետ, եւ տարիքը կարևոր գործոններից մեկն է։ Ու դուք ուզենայիք, եթե անհասկանալի հարց կա, մենք կթարգմանենք հայերեն կարող եք ասել նույնիսկ։
Ես մի հատ արագ հարց տամ, բարև, ողջունում եմ բոլորին, Թալին, մի հատ sense հարց։ Տարիքը կարևոր է neuroplasticity տեսանկյունից։
Ayo. So we used to think that younger is better, but it depends on the type of injury. So if you have a focal injury, so if you have an infant, for example, who has even a part of the brain removed, if not a significant part of the brain removed, if it's a focal injury like that, younger is better because the brain is plastic, and as that infant grows, other parts of the brain can take over that function. It's a different story when we talk about this kind of brain injury where it's not a focal injury like a stroke or a tumor that's removed. This is more an injury that has to do with connections of different networks in the brain. So when you disrupt the brain earlier on, when you disrupt the connections of the brain earlier on, you actually have worse outcomes. So plasticity doesn't help in this scenario, because now you've taken the architecture of the brain and how it's supposed to develop, you've disconnected some of those networks, and now you've set the stage for increasing difficulty over time as the brain would have developed and as these networks would have, for example, come together to support higher level language and higher level organizational skills. We've limited that. So younger is not necessarily better in this type of injury.
Okay.
Yeah. Okay.
And for the prediction of what kind of predictors we have for whether we can have cognitive deficit or not. I mean, I understand that the location is important now. What kind of predictors we have?
So here are the predictors. So usually, in general, time since injury, the recovery period. So the longer time since the injury, the better the outcome. It's typically in the first 2 years. So most of the recovery happens in the first 2 years. And we're talking about severe injuries. We're not talking about concussion, because we'll get to that, and that's a very different profile. So if we're talking about moderate to severe injuries, most of the recovery happens in the first 2 years. And then it tends to plateau after that. We talked about age, that younger is not necessarily better. If the child has already acquired the skill by the time the injury occurs, that skill is more protected. So if you have an 8-year-old who has already learned how to read and they have an injury, most likely the reading is not going to be affected. But if the 8-year-old has not learned how to organize their time and multitask, then by the time they're older, like a teenager, and that skill has to come online and come into play, then they're going to have difficulty. If you have a 4-year-old who hasn't learned to read yet, who has an injury, then because of their deficits in attention and being able to concentrate on things, then they might have trouble with reading. So that's how age comes into play.
Okay.
The length of time that they were unconscious matters, the number of lesions, injury severity, all of these things, these clinical medical variables that would be indicators of injury are predictors of outcome. But what is also important, and you know, we talk about, actually, let me talk about concussion, the predictors of outcome in the milder injuries, and then I'll talk about some additional factors that are important. When we have mild injuries like concussions, the factors that predict longer recovery or poorer outcome are whether or not there's headache. Typically fogginess or dizziness tends to be a red flag. That middle adolescent age range is at greater risk, and there may be some biological hormonal reasons for that, but there may also be some psychosocial reasons for that. If there's a history of other concussions, then the more concussions we have, especially if they're closer together, then we increase the risk of a prolonged recovery. But then there are all these non-injury related variables. The kids who have other bodily injuries, if there's poor coping, if there's a history of depression or learning problems, that's what LD is. If there's pain in the picture, if there's any reason, motivation to exaggerate. So for example, continuing to have symptoms gets them out of a particular class, or it gets a parent's attention. These are all the non-injury related factors that also help to prolong symptom recovery. What I want to stress also is the literature is focused on factors that are medically related that predict outcome. But there's emerging literature also that shows that there are so many other personal, family, and community-related factors that contribute to outcome, especially the farther we go from the injury itself. So, you know, if we want to know how someone's going to do the first few months after an injury, yes, whether or not they were unconscious for a long time, if they had a brain bleed, all of those factors are going to be predictors. But if we're going to look at, you know, 5 years down the road, 10 years down the road, what's going to come up to the top in terms of important predictors of outcome isn't whether or not they had a seizure right after the injury, or what the volume of their brain bleed was. It's many of these family factors. How the family copes with stress. Are they very emotional? Do they fall apart, or do they have a more problem-solving approach? Are the parents warm and set boundaries? Those are the good outcomes. Or are they very either harsh and cold, or hands-off and not engaged? And that second profile predicts poorer outcomes. Family environment, in terms of how resourceful we think the families think they are. Do they feel like they can ask for help? Can they ask for help? Especially, most of the family dynamics has been looked at in terms of the mother, but that doesn't mean that the father's role is insignificant. So the studies that have looked at the mother's ability to buffer the negative impact of an injury. So we know that poor socioeconomic status, like not having enough income and being socially disadvantaged, has a negative outcome of brain injury. But the negative impact of those social factors are less if there's a parent who has a very warm and nurturing parenting style. So these are, and I can spend a whole hour talking about this piece, and we're writing something on this topic alone, but the importance of the community and the family dynamic is starting to get more attention, because there's clearly a lot here that either is a risk factor or a resilience factor when we look at outcomes after a brain injury. I won't belabor this point. That's the whole issue. And I put this cute picture of a mouse here to remind me, there's a series of studies that have looked at how maternal caregiving and nurturing in animals translates into better cognitive function. But that doesn't stop with that particular mother-child relationship. That has a generational effect. So, you know, one set of studies looked at how much a mother rat licks its pup. And that's supposed to be a measure of warmth and nurturing. So the babies that are licked more by their mothers have bigger brains, and they do better on rat memory tests. But turns out that those pups then, when they grow up and they have pups of their own, that effect of that nurturing mother is translated to their offspring. And they've tracked this down to 3 generations. So these family dynamics and relationships and how we build resilience in children impact not only how a child recovers from a brain injury, but potentially can impact how they then contribute, you know, this is all part of epigenetics, is how these behavioral environmental factors can have effects on how genes are expressed, and that can have a consequential effect on the subsequent generation. So very intriguing literature there. And this busy slide to demonstrate to you in a different way that we often think about the one directional effect of genes to our behavior. So we think, okay, genes can change how our brain develops, and that affects how brain and behavior interact, and then you have symptoms. But the reality is that at all of these levels, all of these factors impact each other. So that if we have a negative environmental effect, like malnutrition, then genes can be expressed that then can negatively impact brain development, and then we have a poor outcome. Or psychosocial stress, abuse, violence at home, any kind of injury at home can have that negative effect. On the other hand, if that environmental impact is positive, so warmth in nurturing, warmth in family, enrichment, whether that's language enrichment, social enrichment, then we can have the opposite effect on how the neurochemistry and the neuro architecture of the brain has an impact on outcome. And I think I included this because I think more and more this is becoming very important when we try to understand how a brain recovers from any kind of insult or injury, that the dynamics and the relationships are much richer. And if these are things that we can impact, these are important things for us to know. We may not be able to change, you know, how big the volume of the brain bleed was, or how long a patient was unconscious. Those are not variables that we can change. But if we can change some of these other things as clinicians, in terms of how the family builds language around the injury, how they understand their control and power in a negative situation, how they relate to each other, all of these other things are points of intervention if we're thinking about clinical outcomes. So the bottom line is this very old saying, it's not only the kind of injury that matters, but it's the kind of head. And the kind of head is not just the organic head, but it's complex on many direct dimensions. It's a moving target, and it's molded, but not only by genetics, but very heavily by the environment too. Okay, so I'll stop there and then see if you have any comments or questions, and then we'll move right along to concussions. Okay, so concussions, which are primarily going to be what I imagine you're going to have to deal with the military population that you're working with, is again a milder brain injury. It's on the mild end. It's a biological process that affects the brain induced by physical forces, but that doesn't necessarily mean that the head had to have impact. So it's again a sudden movement of the brain within the skull that's significant enough to cause some imbalance of the chemistry. Symptoms start quickly. You don't necessarily have to be knocked out, passed out. You get better, and we don't necessarily expect scanning to show us any kind of abnormality. These are the signs and symptoms of a concussion or a mild traumatic brain injury. Those two terms I'm going to use interchangeably. You don't have to, your patient doesn't have to have all of these symptoms, but this is a good summary of the types of symptoms that we see after a concussion. And they're basically in 4 categories: somatic, which is all the physical pains, aches. There's some cognitive issues in terms of attention and confusion, disorientation, and the emotional in terms of being very emotionally labile, and sleep is another one. I'm going to skip this section. I'm going to give you all these slides. You can read through them if you want. The metabolic cascade, and the reason I'm showing you this is to show you that the effects of a concussion are very time limited. So if we wait enough time, whatever this imbalance is of all these different metabolites in the brain, naturally, naturally normalize. So this is all this abnormality in these various metabolites over a particular string of time that we understand and we expect should normalize once that period is over. So busy slide again, but if we look at just communication, neuronal communication. There are different aspects of the communication that disruption would be linked to certain symptoms. So migraines could be a disruption of one part, slow reaction time, impaired cognition, and whatnot. I put this here because I think it's really important to understand that in mild traumatic brain injury, that period where there's all that abnormality in metabolites and there's a very increased demand for energy of the brain, understanding what that looks like on a neural level is really important. So if we look at a healthy brain, which is this person here using a PET scan, this is supposedly a normal distribution of energy demands. Okay, so this would be GCS of 15. If we look at this middle brain, so this is someone who we scanned who was in a coma. This was a person who was in a very severe car accident and had been in the intensive care unit for several weeks, comatose. And so we see that there's a very abnormal level, if we compare it to the normal, of energy demand. And the brain's ability to utilize energy to perform its normal functions. What's really striking is this person here. This is a young man who walked to get his brain scanned, a college student at UCLA, who 2 days before had had an injury. He's walking, he's talking. But when we scan him, he looks no different in terms of those energy demands relative to this severe injury. So the point being here is that even if someone is walking and talking and don't seem very impaired, their brain during that week or two where it's going through that metabolic cascade of changes, is in energetically, metabolically, is in the same crisis mode as someone who's in the ICU. So it's really important during that time to make sure that they don't do something so that they're at risk for another injury, or they don't do something that puts them at risk for prolonged symptom recovery. And that's why I'm showing you this picture. A concussion is a clinical diagnosis. There's no single tool, there's no single measure. There are different tools to be able to tap into different symptom clusters, and we'll talk a little bit about that. But ultimately, it's a clinical diagnosis. I'm going to focus on the MACE, which I think, if you're not familiar with it, may be helpful to you as a screener. It's designed for the military TBI population. And I also want to orient you to this website that I thought was very helpful, the Defense and Veterans Brain Injury Center. The link is there. Again, I'm going to give you these slides so you can look at them. There's a lot of freely available information, both in terms of assessment tools you can download and translate, rehabilitation tools, fact sheets for families, for patients, for clinicians. It looks like this. And I'm going to walk you through a few things on this website that I thought was helpful. One of them is the MACE. So we usually use the ACE in our clinic, which is the acute concussion evaluation, but the MACE is the military version. So it's got some specific questions that have to do with a military related injury. It screens for concussion, the actual event itself. It has a cognitive screener. It has a neurologic screener. There's an ocular and vestibular measure. Very, very quick. It can be done in minutes. The other benefit of something like this is that it can be re-administered. So you can re-administer it daily to, once you've established that a patient has had a concussion, you can monitor their recovery and progress daily using this tool. So I think it's a very handy screening device, especially if you're in a situation where there's a lot going on, you don't have a lot of time. This is a good way to monitor symptoms. The other thing that's on this website that I thought was helpful is an algorithm of when to determine when a military personnel needs to seek more medical attention, or when they're ready to gradually go through the steps of recovery. Now, the one thing is, traditionally, up until relatively recently, we used to err on the side of caution. So if we suspected that someone had a concussion, we would pull them out of everything and say, you know, go sit in a dark room, don't do anything, don't look at screens, minimize social contact. And we'd say, we're gonna do that until you're not symptomatic anymore. And that's the complete opposite of what the brain actually needs to recover. I always tease parents, I say, you take your teenage boy, you take their device away, you take their friends away, you take their sport away, you put them in a dark room, and we're asking them to come out when they're not irritable anymore. Well, guess what? That's never gonna happen. And in fact, it's counterintuitive. It's like if I strain my ankle and okay, the first 2 days, I'm gonna not put pressure on my ankle. But if I don't put pressure on it for months and years, 2 years later, that ankle is still gonna hurt, not because of the initial injury or strain, but because I've deconditioned it. So part of the recovery from a concussion is to pull back so we avoid another injury, but to re-engage in a very methodical and safe way, because if I were to write a prescription for recovery after a concussion, I would say, try to get your back to normal as much as you can. So with that note in mind, the website I was sharing with you has very specific guidelines that are very helpful in terms of how to get a military personnel who's had a concussion in a controlled fashion back to a baseline. So stage 1 is rest, and you can read through all of these things, what to avoid, what not to do, what to do. And the idea is that if they stay in this stage for, I believe it's a day, with no new symptoms, then they progress to the next stage. That gradually gets them to stage 2, stage 3. I'm not going to go through all the details. Stage 4 gradually gets them back to normal functioning in a safe way. So that's the idea, is when there is a concussion, initially we're going to step back, rest very briefly, but within the second, third day, we want to be able to re-engage the patient with daily activities that have to do with thinking, socializing, physical, so that they can avoid a prolonged recovery and actually aid in their recovery. So the summary of concussion outcomes, mild traumatic brain injury outcomes, is that we know the course, we know it's self-limiting, we know it's predictable. In adults, it's usually 2 to 3 weeks. In children, it's a little bit longer. If during that time we're able to slowly re-engage with things, manage symptoms, we know that the symptoms should go away. There shouldn't be any long-lasting consequences from this type of injury. So when we do see long-lasting consequences, we usually have to look at some other factor that's part of the picture. So usually it's 20 to 25% is the current estimate of concussion cases don't recover in that 2 to 3 week period that we know they should. And so when they don't, we look at other factors, like the social factors, like the pre-injury unrelated factors. Are there, is there a mental health component in the mix? Is there a migraine disorder in the mix? And so those are the things we want to know so that we can treat the symptoms. I put this here these are all the symptoms of concussion in the middle, because I wanted to point out how much overlap there is between concussion symptoms and a whole host of other things that we often ignore when we see someone with a brain injury, with a concussion. So when they come to us and they say, you know, it's been 2 months, it's been 3 months, it's been 2 years even, I still can't think well, I have trouble sleeping. It's very easy to say, oh, this is post-concussive syndrome. When the reality is, there are all of these other factors that may be maintaining the symptoms. So just to talk about a few of them. If there's stress, worry, or anxiety, if all they see on TV or hear from a parent is that, oh my God, once you have a concussion, you will never get better, or you'll have CTE, or you'll never be able to play your sport again, or be a good student again. If they're constantly worried about that, then that alone is enough to cause concentration difficulties. If there's withdrawal from their physical activity, from their normal routines, from their friends, that alone is enough to create this cluster of concussion symptoms. Headache and migraine is another one. You know, sometimes we work a lot with young people, and that's when migraine disorders would have happened anyway. It's possible that a concussion triggered a genetically vulnerable migraine disorder. But at that point, it's not the brain injury that we're dealing with a migraine disorder. So if someone has extreme pain, of course, they're not going to sleep well, and they're not going to concentrate, and they're going to be moody and not do well in school. So again, this to show you that there's a very, very high overlap in all of these symptoms with concussion. So if we stop calling it concussion and we treat these other things, some of which may be completely unrelated to the injury and others may be triggered by the injury but are now being maintained by other factors, then we can be more effective in helping to reduce the symptom load. So I'm going to stop there with concussion, and again, see if you have any questions, any comments before we move on.
I have one. Can I?
Sure.
It's very good slide to see the overlap between different aspects in a frame of concussion. And my question is whether we need to start with pharmacotherapy if we see psychiatric comorbidity here, such as depression, low energy, sometimes dissociation, and so on. How long we can wait and when we can start with pharmacotherapy?
I think that's a good question, and I think it really depends case by case. If there's a long-standing history of depression, for example, that's not amenable to treatment, then that might be something that is started earlier. There's some medications that help both with mood and with pain, for example. So those are all options that are on the table. In other cases, just explaining to someone that, you know, their symptoms are time limited, that they're expected, that alone may be enough to lift the depression. If the depression is really secondary to all the changes that have happened in their life and all the confusion there is about symptom and symptom management. So pharmacotherapy can definitely be part of the picture if it's clinically indicated, and it's really, again, case by case, and it depends on what other symptoms are at play. So if there is, you know, pain and migraine, then different medications can be considered to help with the pain along with the mood.
And what about psychotherapeutic interventions, Talin? Very often soldiers, they cannot concentrate on the meeting with the specialist, and they want to do fast everything and finalize with everything. What kind of recommendations we have for concussion? And also with psychiatric comorbidities with these soldiers, I mean.
So again, it's case by case because every soldier is going to be different. Their symptom profile is going to be different. But in general, I would say start off with some psychoeducation. So just, you know, there's a recent study that was published that looked at just psychoeducation alone after a concussion is a strong predictor of less time in terms of symptom recovery. Once you explain to someone why they're feeling the way they're feeling, that it's normal, it's expected, we know the outcome, and whatever difficulty they have, we have some suggestions for, just that alone usually is enough to reduce the amount of worry and stress, to put them at a place where they can be open to more interventions. I would imagine, I don't treat soldiers, so this is just a general clinical sort of insight or idea in that, you know, if there's a lot of clinical issues that are on the table at once, prioritize the pieces that have a more, are going to have a more generalized effect. And I'm going to come back to this at the end, and I'd like to talk about it a little bit more. But it's, you know, they have pain and they have a leg injury and there's PTSD and there's concussion and there's all these other things on the table. How do we prioritize what we're going to tackle first so that it has the most impact, so that from there we can start peeling some of the onion layers? But to right off the bat go into a more intensive psychotherapeutic situation that requires reflection and attention just may be counterproductive because they're not in that mental space. So starting with something that's much more structured and time limited, some basic relaxation or cognitive behavioral kinds of techniques, psychoeducation, just to kind of ease the stress on the system is probably the best, most effective way to start. But I want to come back to that intervention piece because I think it's really important. Right? Oftentimes in military TBI, I'm not going to belabor this too much, is also post-traumatic stress disorder or just post-traumatic stress, even if we don't meet the disorder criteria. I'm sure you're all familiar with, you know, PTSD, its intrusive memories of the incident, avoidance of the reminders of the incidents, and the whole range of mood and cognitive impact it has. The symptoms may have on general functioning. I'm going to go back to this slide because I want you to think about symptoms of PTSD and how much overlap there is between the concussion symptoms and PTSD symptoms. So if you're working with the military population, it's impossible to ignore the impact of a comorbid stress response to symptoms of concussion. Okay, so just have that in mind, that many times you may have a combination of etiologies and reasons why you're seeing the cluster, symptom cluster that you're seeing. I put this book up there. It's a very thick book, little challenging to read because it's so dense with examples, but it's an amazing resource that I honestly think every clinician should read this because not just mental health clinicians, anyone who works in a clinical capacity with patients would benefit from this book that explores how trauma historically changes the way our body reacts to experiences and how often symptoms are related to these past traumatic experiences. And when you use the trauma frame to evaluate someone clinically, you have a much wider window on where some of their symptoms are coming from. I'll give you a couple of examples in our general concussion clinic. We usually see youth and young athletes. every time someone comes and their symptoms are not explainable, so they'll say, you know, I had a concussion a year ago, and ever since then, I feel dissociated. I had a concussion 2 months ago, and I can't read anymore. And the list goes on and on and on. Without exception, in those situations where the symptom presentation doesn't match what we know about brain injury, every single time there's a history of trauma. Sometimes it's known to them, sometimes it's unknown to them. And the trauma doesn't have to be something so devastating and severe where there is active PTSD, but there's something in their psychology that is connecting their current symptoms to their profile. So this book entitled The Body Keeps the Score is exactly about that, that our aches and pains, the way we experience aches and pains, the way we experience novelty has a great deal to do with our history of stressful experiences. And who doesn't have some level of stressful experience, even if it's not considered PTSD. So the bottom quote here is, if an organism is stuck in a survival mode, its energies are focused on fighting off unseen enemies, which leaves no room for nurture, care, and love. For us humans, it means that as long as the mind is defending itself against invisible assaults, our closest bonds are threatened, along with our ability to imagine, plan, play, learn, pay attention to other people's needs. So again, clinically, when we're working with people, taking into account their trauma, their stress history, just gives you much more tools when you're trying to understand where their symptoms are coming from and how to help them. And I think without that additional piece of information, you as a clinician are at a disadvantage because you only see part of the picture, you're not seeing the full picture. So this book has very concrete examples, great chapters on different methodologies to treat trauma, and just biologically lays out the connection between traumatic and stressful experiences and outcomes. So if you're at all inclined, I would absolutely encourage you to read this. I'm not going to go through these numbers other than to say in the military population, before we even do that, 90% of the population is exposed to at least one traumatic event in their lifetime, but a much smaller percentage will develop PTSD. But again, the traumatic experiences are very common, and they need to be incorporated in clinical care. In veteran populations, the rates of lifetime PTSD are higher than civilians. And you're more likely to have, in the military and civilian population, you're more likely to have PTSD if there is a history of brain injury. So the two disorders, conditions, PTSD and TBI, when they're present, they're more likely to be present together than not. And that's not surprising because many times, at least in the military population, a traumatic brain injury is often related to a stressful event. I'm not going to go through all of this. You can look at that if you're interested. There's a little bit of information here about why those two conditions go together. There's overlapping physiology, there's psychiatric comorbidities, and there's an emotional salience. There's an emotional weight on when there is an event like that causes a brain injury, that disrupts our ability to process information, to reconstruct memory. So it's not surprising then that those two conditions, at least in the military group, would go hand in hand. So a little bit about, I know we're running close to time, a little bit about symptom management and interventions, and then we can stop. So when we're dealing with a traumatic brain injury, especially with a mild concussion, what we want to do is treat all the symptoms. So not necessarily treat the brain injury, but treat the symptoms. So if there is pain, whether it's a headache or some other muscular pain, we want to treat that. We want to make sure that sleep is normal and healthy. We want to address any kind of memory issues with strategies and whatnot. I think with the population you're working with, and Lilith asked a good question, is there really has to be a multidisciplinary, interdisciplinary approach. Because if we only look at it psychologically, we're going to miss the psychiatric piece, the neurologic piece. If we only look at this as a neurologic disorder, we miss the mental health component. The, you know, a person doesn't come to a brain injury in a vacuum. You know, they bring who they are and their past experiences to the injury, and without an understanding of who they were before and what sort of predetermined conditions and vulnerabilities they have, it's hard to see the big picture of what needs to be addressed. A good evaluation informs your intervention. So I think that's an important place to start. So whether you use some screening tools or come up with your own evaluation, psychological, neurologic, cognitive, it gives you a good place to start in terms of how to prioritize the intervention and what to help you determine how to best initiate the intervention. Again, treat the symptoms, not necessarily the TBI. We talked about that. In terms of prioritizing symptoms, you want to hit high value targets that have trickle down effects. So for example, someone comes to you and they have 10 things that they're affected by, but they have a headache that's a 10 out of 10. If we target that headache, it'll likely have a downstream effect on a number of other things. It'll help with their mood, it'll help with their motivation, it'll help with their ability to concentrate. So finding out what those high value targets are instead of trying to treat everything all at once. But then also to not ignore the low-hanging fruit. So this is the easy stuff. Is again, when we have someone that comes to us with 10 things that they're struggling with, the easy things that are manageable are things like hydration. You know, are they drinking enough water? Are they getting enough sleep? Are there other things that are very easy to change and could have a positive influence on their symptom trajectory? And let's not ignore those. The no-brainers are sleep, hydration, exercise, routine, and socializing. Those are the basic building blocks of us feeling better. And so let's not ignore those relatively easier things before we do more complicated interventions. The environment can make or break outcome. You know, sometimes someone who needs rehab will be taken out of an environment, taken into a different environment, given lots of intervention, but then they go back to the environment that was originally stressful or originally mentally taxing. So ignoring that back and forth is also not going to be helpful. So being able to provide intervention in the environment that they have to function in, or at least considering that, becomes important. We talked about the social networks. It's of utmost importance for the network to also be on board, whether these are people who have parents or children or spouses or friends, so that that everyone's on board with what's happening, that they don't get mixed messages from different people or get messages that are not in their best interest clinically. And then at the end of all this, I mean, this is, you're probably dealing with more acute situations, so this last piece may not be as relevant, but you know, if we think about people with a history of military brain injury, we want to be able to help them make meaning of that experience, even if they've ended up with some kind of disability or impairment. Finding a way to make meaning of that negative experience is really therapeutic. So understanding why they did what they did, being able to give to others in some way, building self-esteem, building confidence. And there's, you know, culturally, there's going to be so much variability on what this looks like with the population you work with. But at the end of the day, you know, a negative, stressful experience can be shaped by slowly, finding meaning, I think, is a good way to characterize it, of the challenging, stressful thing that happened to them, life-changing thing that happened to them. So that could be an ultimate goal. And then trauma intervention. I can't stress how important that is, to be able to at least look at your brain injury patient with the trauma lens, so that important things aren't missed. I'm going to read you one last, hopefully inspiring quote from the book I presented to you, and then we could stop, and I'm happy to answer questions. Trauma really does confront you with the best and the worst. You see the horrendous things that people do to each other, but you also see resiliency, the power of love, the power of caring, the power of commitment to oneself, the knowledge that there are things that are larger than our individual survival. And in some ways, I don't think you can appreciate the glory of life unless you also know the dark side of life. So I think approaching patient care with this kind of mindset will help not only the people you work with, but also yourself as you're going through some really challenging and trying times. That's all I have. That's my email address, but I'll go ahead and share the slides with you. So if you want to go through and look at anything, I'm happy to share that. And now if you have any questions or comments, I'm happy to listen to them.
Thank you very much, Talin. We have Hrant Avanesian wanted to ask a question, or just thinking for this presentation.
I think he was applauding.
Oh yeah. So they were yes. Sorry.
No, so in terms of it's got կոպիքշ դե որ դուք անգլերենով ներկայացրեցիք, մենք էլ անընդհատ մտածում ենք թարգմանենք թե չէ, բայց փորձից գիտենք, որ երբ որ փորձում ենք թարգմանենք մի մասը անգլերեն, մի մասը հայերենով, հիմնական միտքը գորում է։ Քանի որ ձայնագրությունը արդեն մեզ մոտ կա, եւ եթե դուք թույլ տաք, այս ձայնագրությունը հետո մենք կներկայացնենք մեր գործընկերներին, որ եթե ինչ-որ անգլերենով դժվար է իրանց համար, եւ ես երթակատուրը կփորձենք բացատրենք եւ թարգմանենք։ Դա ինձ թվում է ավելի ճիշտ լինի։
Անպայման, այո։
Դուք հարցեր ունեք։
Այո, կներեք, էլի շատ եմ հարցեր տալիս։ Talin, concussion-ի հետ կապված, դու նշեցիր, որ 2-ից 3 շաբաթ մենք կարող ենք ունենալ դրական դինամիկա, եթե մենք ունենք concussion։ Եթե մենք ունենք comorbid psychiatric condition, dissociation, acute stress disorder-ի ինչ-որ գանգատներ, depression, premorbid depression, concussion-ի գանգատները 3 շաբաթից ավել կարող են տևել, չէ՞, այսինքն psychiatric comorbidity-ն ինքը կվատացնի իրանց վիճակը։
Yeah. So if there is a premorbid condition or comorbid condition, it'll lengthen that time, but the metabolic disruption usually is between 2 to 3 weeks. So what's happening in the brain doesn't necessarily change. The chemistry of the brain will settle down in 2 to 3 weeks, okay? Mm-hmm. But once the body is triggered to feel pain, so you've sort of lowered the threshold for symptoms, so that they're more likely to continue to experience those symptoms way past that period. But that's why when we see symptoms drag on for more than a month and a half, 2, then we start thinking about it not as a concussion, but as whatever these other things are. It's like, I always give the example, you know, a snow globe, right? So those globes where there's a little character in there and you shake the globe and all the snowflakes go. Concussion is that. It's like, take the globe where all the snowflakes are at the bottom, we shake the globe, and now there's all this snowflakes everywhere. But if you put the globe down, we know within a minute or two, all those flakes are going to settle. It has to settle. So if this flakes aren't settling, there's something else in there shaking up the globe.
Mm-hmm.
So we have to treat whatever that other thing is.
Mm-hmm.
So, and it's not helpful to, when we're talking to patients about, that's why this whole post-concussive syndrome makes me nervous a little bit, because especially people who are not very comfortable with their psychiatric vulnerabilities, it's very hard for them to accept that their depression or their anxiety or their migraine is causing their current symptoms. And we don't do them service by keeping calling it concussion, 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 because they get fixated. And I have a brain injury. I have a brain injury, and that's why I can't think straight. I'm never going to be the same again. That's why I can't work, and that's why I'm in a bad mood. But if we separate the concussion from whatever it is that needs the clinical intervention, then we're able to treat the piece that's actually going to make the difference. So that's why I worry about calling it a concussion way past that time period when we know the concussion should have settled. Again, if the injury is much more complicated than that, then the picture is different. Like even if it's a mild injury, but there was some skull fracture or there's a bleed, you know, then there may be a longer stretch of time. But if it's a simple, uncomplicated, single concussion, after that period of time, I stopped calling it concussion treatment. We call it treatment for any number of the other things that are now driving the picture, even though the concussion probably lowered the pain threshold, the sensory threshold for these other things to have more life.
Mm-hmm. Okay.
Thank you very much. Vishal Serkan.
I don't have a question. I just want to tell thank you very much. It's a lot of information, and I think we need time to reduce all this information to come to have some conclusions. But just thank you so much. It was important.
Yeah, Talin, I would like to echo the same thing. I know you made yourself available in a very short period of time, and the wealth of information is really very much relevant to what most of us are experiencing in here. So our gratitude to your availability, and hope we can be in further collaboration and communication with various projects and more presentations.
Absolutely. My heart's
Այո, շնորհակալություն ասենք եւ բոլորս շատ կարևոր ենք համարում ձեր ելույթը եւ Խաչիկն ու Ալենը ինձ թվում է կտարածեն, որ հայերեն ավելի շատ աուդիտորիա ունենանք։
Այո, այո։
Ես էլ եմ ուզում ասեմ մերսի շատ Թալինին ու շնորհակալություն փորձով ու ամեն ինչով կիսվելու համար, որովհետև այս իսկապես շատ կարևոր էր մեր համար ու կարծում եմ դու դեմ չես լինի, որ եթե հարցեր ունենանք, քո հետ կապի մեջ լինենք ու շատ շնորհակալություն քեզ։
Yes, Shad Shnagal. It's my pleasure. My heart's with all you guys. So if you, I'm happy to collaborate or expand on anything. Just let me know. Alan and Khachatur have my contact information. Thank
you very much, Talin. At least I learned one thing, because 2 days ago I was dealing with a wounded soldier who was diagnosed as concussion, and they told me he needs some psychological help. And then when I asked to neurologist how long this is going to be, he said this is for entire life. So I learned that there's no concussion for entire life. So we need to review it once more. And thank you very much. So what I think Հուսով եմ, որ մենք Ալենի հետ մի քիչ կարճ կփորձենք սլայդները վերլուծել նրանց համար, ովքեր
Այո։
եթե օգտակար լինի տեսնել, շատ շնորհակալություն։
Հա։
Բարի գիշեր։
Շնորհակալություն, հաջողություն ձեզ։